بسم الله الرحمن الرحيم. Diet therapy for surgical condition under supervision of Professor Dr. Amani and Assistant Professor Dr. Walaء الدين, prepared by Amani and Iman Muhammad. Objectives. Our general objectives are: at the end of this lecture, each postgraduate student will be able to upgrade knowledge, practice, and attitude regarding diet therapy for surgical conditions. Specific objectives: discuss objectives of surgical condition management, discuss pre-operative nutrition support, discuss type of nutritional support, discuss enteral feeding, benefits, contraindication, complications, and enteral feeding solutions. Discuss parenteral enteral feeding, benefits, indication, complication, and enteral feeding solution, and parenteral feeding solution. Discuss recommended and avoided food for surgical condition. Outlines: introduction about surgical nutrition, objectives of surgical condition management, pre-operative nutrition support, types of nutritional support, enteral feeding, benefits, contraindications, complications, and enteral feeding solution. Parenteral feeding, benefits, indication, complication, and feeding solution. Recommended and avoided food for surgical condition. Clinical nutrition for surgical patients begin with a thorough review of the basis of medical nutrition therapy for surgical patients, including nutritional assessment, the role of surgical diet, and the indications and contraindications for specialized nutrition support. Early oral feeding is the preferred mode of nutrition for surgical patients. Avoidance of any nutrition therapy bears the risk of underfeeding during the post-operative course after major surgery. A patient who is malnourished prior to surgery typically requires longer hospital stays, has more nutrition-related complications during and following his or her hospital stay, and he is likely to experience a greater number of infections and poor health outcomes. Therefore, a central pre-operative goal is to help assure that the patient achieves the greatest nutritional potential going into surgery. This may mean postponing any non-critical surgery in order to help the patient retain or achieve improved nutrition status. Surgical nutrition support is usually according to the patient's condition and according to the type of surgery, whether it is cardiac, hepatic, or gastrointestinal surgery. Objectives of surgical conditions management: integration of nutrition into the overall management of the patient, avoidance of long periods of preoperative fasting, re-establishment of oral feeding as early as possible after surgery, start of nutritional therapy early as soon as a nutritional risk becomes apparent, metabolic control as control of blood glucose, reduction of factors which exacerbate stress-related catabolism or impair gastrointestinal function, minimized time on paralytic agents for ventilator management in the post-operative period, early mobilization to facilitate protein synthesis and muscle function. Pre-operative nutrition support. Pre-operative nutrition is indicated in severely malnourished patients undergoing major surgery, gastrointestinal tract surgery for 7 to 14 days if patients can be safely postponed. Enteral nutrition is the preferred route for pre-operative nutrition support. Pre-operative nutrition should be administered to patients who is anticipated to be unable to meet their nutrition needs orally or enterally for a period of 7 to 14 days. Types of nutritional support: enteral feeding, oral feeding, nasoenteral tube feeding, and invasive tube feeding. oral feeding, this remains the best form of nutrition. It is very easy for a patient to slip insidiously into malnutrition if there is the slightest doubt about the amount of oral intake. It is advisable to pass a nasogastric tube for feeding. Nasoenteral tube feeding. It is indicated in patients whose intestine can tolerate food and there is no contraindication to the entry of food in the gut, but who cannot or don't take food orally, where feeding into the stomach is contraindicated, as in pancreatitis. A nasovaginal tube can be inserted for feeding. Invasive tube feeding. Patients who cannot have a nasogastric or nasovaginal tube based, as in inoperable carcinoma of the pharynx or esophagus, or those who need long-term feeding for months or years, should have a percutaneous feeding tube positioned gastrostomy or jejunostomy. Benefits of enteral feeding: decrease infectious complications, maintains gut integrity, maintains immunological integrity, less bacterial translocation, attenuate catabolic response, immunonutrition, and cheaper. Contraindication for enteral feeding: active gastrointestinal bleeding, interactable vomiting, ileus or bowel obstruction, profuse diarrhea, severe enterocolitis, ischemic bowel, aggressive support, not warranted. Enteral solutions. We will start with kitchen feeds. Provided the feeds are well designed and are liquidized properly in a food processor, kitchen feeds are the most economical tube feed available. Caloric information per feed is usually not accurately known, and hence it is difficult to determine the exact calories being provided. Non-homogenized solid material may block fine bore feeding tubes, a problem which is less with commercially available feeds. Proprietary enteral formula. Commercially available powdered feeds derived from milk or soya bean with various additives are complete feeds containing a balance of carbohydrates, proteins, fats, vitamins, minerals, and trace elements. Because they are flavored, they can be used for oral as well as tube feeding. They are more expensive than kitchen feeds, but are unlikely to clog feeding tubes, and it is possible to know the exact number of calories being provided. Complications of enteral feeding: gastrointestinal complication, mechanical complication, and metabolic complication. Gastrointestinal are distension, nausea and vomiting, diarrhea, or constipation. Mechanical are malposition, blockage of feeding tube, sinusitis, ulcerations, or erosion. Metabolic are infectious complication, aspiration, pneumonia, and bacterial contamination. Parenteral nutrition. Peripheral, partial, or total parenteral nutrition. It is being increasingly used because it is obviate the use of a central line and its attendant complications. It involves infusion of total parenteral nutrition solution via an ordinary cannula or via a peripheral long cannula where the tip lies in the upper arm with a relatively higher blood flow. Central or total parenteral nutrition. Infusion of a total parenteral nutrition solution is almost done via a central venous line. This is because total parenteral nutrition solutions are very hypertonic and need a vein with a rapid blood flow to dilute solution as soon as it enters the body. Benefits of parenteral nutrition: greater caloric intake, more expensive, complications, technical expertise. Indication of parenteral nutrition: abnormal gut function, not able to be fed enterally by 5 to 7 days, prognosis warrant aggressive nutritional support. Parenteral solutions: hypertonic dextrose solutions 20% to 50% were the first solution used for total parenteral nutrition. These have to be infused via a central line into a major high flow vein to avoid thrombophlebitis. It was soon realized that providing all the calories via glucose alone has disadvantages. Patients develop essential fatty acid deficiency within a few weeks in the absence of lipid infusions. Lipid solutions provide about 9 calories per gram, as opposed to about 4 calories per gram from dextrose. Lipids are essential in stressed patients who will metabolize lipids preferentially over glucose during stress phase. Amino acid solutions: these must be distinguished from other protein providing solutions such as albumin or plasma. Both these later solutions contain large protein molecules which have to be broken down to amino acid before they can be used for protein manufacture. Complications related to parenteral nutrition: mechanical complications, metabolic and infectious complications. Mechanical complications related to vascular access technique. These complications are pneumothorax, air embolism, arterial injury, bleeding, brachial plexus injury, catheter malplacement, catheter embolism, thoracic duct injury. Related to catheter in-tube, venous thrombosis, and catheter occlusion. Metabolic complication: abnormalities related to excessive or inadequate administration, hyper or hypoglycemia, electrolyte abnormalities, acid-base disorders, and hyperlipidemia. Hepatic complications as liver steatosis, cholestatic liver disease, cholecystitis, bone diseases and bone pain, fractures, hypercalciuria. Infectious complication: insertion site contamination, catheter contamination, improper insertion technique, contaminated total parenteral nutrition solutions, contaminated tubing, and septicemia. Food recommended and avoided for surgical conditions: clear liquids, full liquids or soft liquids. Post-operative diet: 4 to 12 weeks after surgery. Eat 6 to 8 times a day. Post-operative diet: low fiber, peeled and seeded fruits, cooking vegetables, avoid bran or very high fiber. High protein, poultry without skin, fish, lean meat. Low fat, avoid excessive fat like yogurt, milk, cheese. Calories: bread, pasta, rice, and cereal. Fluids: most patients require 6 to 12 cups per day of non-alcoholic fluid per day to maintain adequate hydration, as water, tea, and juice 100%. Thank you.